Good morning, everyone, and thank you for joining us. We'll get started on the webinar. Today, our speaker is Mr. Alex Zheng. Alex joined BCIRPU in October 2017 as a biostatistician and researcher. A graduate of the Masters of Science in Biostatistics program at the University of Toronto, Alex brings over 7 years of research experience from his time at the Hospital for Sick Children, also known as Sick Kids, in Toronto, and at the Beth Israel Deaconess Medical Center in Boston. His main role at our unit is to provide statistical support and analytical prowess to the many projects conducted at the unit. If you have any questions or comments during the presentation, please use the chat box at the bottom of your screen and I will ask them on your behalf. After the presentation, you may unmute your audio line to ask questions, or we will monitor the chat box for questions or any comments that you may have. And Alex, I'll pass the ball to you whenever you're ready.
Thank you much. Thank you very much for the introduction, Anita, and good morning, everybody. My presentation today will be on a study we did that looked at the relationship between injury, opioid prescription, and a potential illegal drug overdose. So first, I would like to show the a time trend of the illegal drug overdose deaths in British Columbia over time. And what we see is that the rate of deaths has been fairly steady from 1994 to 2015, with a sharp increase starting in 2016, with a dip in 2019 before spiking up again in 2020. So this increase in 2016 has led to a declaration of a province-wide public health emergency in British Columbia. And the increase in deaths were attributed to an introduction of fentanyl and into the local drug supply, and also over prescription of opioids, mainly for pain management purposes, leading to problematic drug use. Our focus on the study was on the Fraser Health Authority region because it has the highest number of overdose deaths. Even though this was mainly due to the fact that they also had a larger population, because they also has one of the lowest rates in the province once population is accounted for. The epidemiology of these overdose deaths in Fraser Health was that they mainly occurred in private residences. They occurred among men of working age, and they occur across most of the neighborhoods, so there's no clustering effect. And it was made worse by COVID-19, as we see in the uptick in 2020. So what this means is that mainly because of the fact they occur, the events occur in a spread out fashion, is that any focused efforts at the point of overdose were either not as effective as we want or inefficient. As a result, we believe that more upstream measures are needed, particularly to identify that are most at risk of a potential overdose. So to do this, we incorporate a retrospective cohort design using a few linked administrative data sets in order to characterize this relationship between an injury, pain management medication of either an opioid or an opioid agonist therapy, or OAT for short, and a potential illegal drug overdose. Our study period was the fiscal year of 2012 to 2017. And our inclusion criteria was if they presented to a Fraser Health emergency department with an injury, that they were a Fraser Health resident and of working age at the time of their injury. This was our index event, and if they had multiple injuries that we captured during our study period, we took the first injury as the index event, and this is our index stage. We also were interested in whether the injury was work-related or non-work related. And between the start of our study period and the index stage is what we call a pre-injury stage. Here, we were interested in their prescription of pain management medication, and we categorize that as either just being prescribed neither, being prescribed opioids only, being prescribed OAT only, or given both. So this will show that whether they were exposed to opioids before their injury. And then between the index stage and the end of our study period is what we consider our post-injury stage. Here, again, we were interested in their prescription. So categorized in the same way of either neither, being prescribed opioids only, being prescribed OAT only, or both. And at the end stage is either that they had an illegal drug overdose or the end of a follow-up time. Some other variables we were interested in were the year of the injury that the injury occurred, the sex of the individual, the age, and the income quintile of the neighborhood that they lived in. And the income quintiles is classified between 1 and 5, 1 being the least well off and 5 being the wealthiest. So this is sort of our indicator of their socioeconomic status. We have 3 main objectives in this study, which incorporated different stages. The first objective was to determine the factors associated with post-injury prescription of opioids and OAT. And to do this, we used the first 3 stages. The second objective was to determine the factors associated with illegal drug overdose risk. And to accomplish this, we used all 4 stages. And the third objective was to characterize the difference between those that were prescribed opioids only and those that were prescribed OAT either by itself or in conjunction with opioids after their injury. And to do that, we focused only on the post-injury stage. We used 7 data sets, administered data sets in this study. They were all linked by PopData BC. They were NACRS, which had the emergency department information, the discharge abstract database, which has the hospitalization information, vital statistics, which has the information on deaths, BC Cancer Registry, which has the cancer-related information, and we used cancer diagnosis as a censoring event because we know that cancer patients are often prescribed opioids as part of their cancer treatment. So those prescriptions are unrelated to their injuries. We also have PharmaNet, which has the prescription information, and WorkSafe BC, which has the information related to work, and Stats Canada for the census information and where we get our income quintiles from. And here you can see how different data sets are used for each variable of interest that we had in our study. So for our first objective, which was to determine the factors associated with post-injury prescription of opioids and OAT. For this objective, we use a multinomial regression model in order to determine the association between the odds of being prescribed opioids only, OAT only, or both after the injury and the variables of interest. So outcome variable was the categories of post-injury prescription with being prescribed neither as a reference category. And our variables of interest were the year of injury, sex, age, whether the injury was work-related, and their pre-injury prescription, categorized in the same 4 levels, and their income quintile. For this analysis, we had 281,000 injury events, and these were to unique individuals because we only captured the first injury event. About 45% of them had a post-injury prescription of opioids only, 1% had a post-injury prescription of OAT only, and 1.5% had a post-injury prescription of opioids and OAT, which also means about over half of the individuals who had an injury did not have a prescription of either after their injury. What was very interesting was we found that everybody who had an opioid prescription before their injury had an opioid prescription after the injury. And this was the case with an OAT prescription as well. So that everybody who had an OAT prescription before the injury had an OAT prescription after the injury, either by itself or in conjunction with opioids. And here I'm presenting the results from the multinomial regression model. This one is focusing on a post-injury prescription of opioids only. On the x-axis, we have our variables of interest and the comparisons used. On the y-axis, we have our odds ratio. And for odds ratio, an odds ratio of 1 means there's no effect. Above 1 means increase in odds. Below 1 means decrease in odds. And it's plotted on a logarithmic scale because I think that better reflects the effect sizes, as a ratio of 10 means a 10-fold increase, and a ratio of 0.1 means a 10-fold decrease. They're similar. They're the same in fact in terms of effect size. So what I would like you to focus on here is this big bar in the middle, which has a larger effect than everything else combined. And this is showing that people that were prescribed opioids only before their injury had 185 times the odds of prescribed opioids only after their injury. Next, this is a result showing those that were prescribed OAT only after their injury. And again, we see two big bars in the middle, which has effect sizes that trumps everything else. And these were people that were prescribed both opioids and OAT before the injury, and people that were prescribed that were prescribed OAT only after their injury. With the bigger bar being, if you were prescribed OAT only before the injury, you had 319 times the odds of being prescribed OAT only after the injury. Next are the results for those that are prescribed both opioids and OATs after their injury. And again, we have two big bars in the middle, with the bigger bar being that if you were prescribed both opioids and OAT before the injury, you have over 800 times the odds of being prescribed both after the injury. So taken all together for this objective, what we found was that pre-injury prescription heavily predicts post-injury prescription of opioids and OAT. This in itself was not particularly surprising because doctors will likely continue to prescribe treatments that were effective before the injury. And at the same token, patients will also likely continue to request the same kind of medication if it was effective before. What was surprising was the magnitude of this effect, because pretty much everybody that was exposed to an opioid or an OAT were prescribed the same kind of treatment afterwards. And for next objective, which was to determine the factors associated with illegal drug overdose risk. For this objective, we use a survival model or Cox proportional hazards regression model in order to determine the association between the risk of an illegal drug overdose and our variables of interest. For this model, our outcome variable was time to overdose at the end of follow-up with a cancer diagnosis or a non-overdose related death as a sensor. Our variables of interest were year of injury, sex, age, whether the injury was work-related, and a post-injury prescription was a time-dependent variable, so it would be the time exposed to neither opioids only, OAT only, or both types of medications after the injury, and income quintile. For this analysis, we removed all individuals with a pre-injury prescription of opioid or an OAT because we found that they're so heavily associated with post-injury prescriptions from the previous analysis. So for this analysis, we had over 172 injury events to unique individuals. About 0.4% of them had a illegal drug overdose event that occurred during our follow-up period, and about 1.4% of them had a sensor event due to a cancer diagnosis or a non-overdose related death. And here are the results from the Cox regression model. Again, on the x-axis are our variables of interest. On the y-axis are the risk ratios. And a risk ratio 1 means there's no effect. Risk ratio above 1 means an increase in risk. Below 1 means a decrease in risk. And again, it's plotted on a logarithmic scale to better reflect the effect sizes of ratios. And what we see here is, again, there are two big bars in the middle, which show that if the individual was prescribed OAT only after the injury, or they were prescribed both OAT and opioids after the injury, they had 28 times to 31 times the risk of those that were prescribed neither. However, we know that OAT is the gold standard treatment for opioid use disorder. So that's why and the fact that OAT is not prescribed just for pain management purposes, that's why we believe this increased risk is attributed to these individuals developing an opioid use disorder, as opposed to the OAT prescription itself increasing the risk. So we can interpret this as if the individual developed an opioid use disorder, they had 28 times the risk of an overdose event. Some other risk factors we identified were being male, having an opioid prescription, and those living in the lowest income quintile. Some protective factors we found were age, and if the injury was a work-related injury. So we found this protective effect of a work-related injury very interesting, because part of our the epidemiology of the overdose deaths that occur in Fraser Health was that most of them were of working age. However, with this analysis and with limitations to our administrative data sets, we're not really able to tease out whether this protective effect was due to, say, the return to work protocols employed by WorkSafe BC, or the fact that you have to be employed in order to file a WorkSafe claim. So this could be just an employment status effect, or it could be a healthy workers effect, where people who are working tend to be healthier in general, both physically and mentally. And next, on to objective 3, which was to characterize the differences between those that were prescribed opioids and those that were prescribed OAT, either in addition to opioids or by itself after an injury. For this objective, we used a logistic regression model in order to determine the association between the odds of being prescribed OAT versus opioids only, and our variables of interest. Our outcome variable is the binary outcome of either being prescribed opioids only or OAT. This means we also got rid of everybody who was prescribed neither after the injury. Our variables of interest were the year of injury, sex, age, whether the injury is work-related, and income quintile. And again, we removed everybody that had a prescription of opioid or OAT before the injury, because there's a strong association between pre and post-injury prescriptions. And for this analysis, we had over 58,000 individuals. About 97% of them had an opioid-only prescription, and about 3% of them had an OAT prescription. The results from the logistic regression model are shown here. On the x-axis, we have our variables of interest. On the y-axis, we have the odds ratios, again, plotted on logarithmic scale. Here, our effect size is a lot closer in range. And we found that being younger, being male, and living in the lowest income quintile increased the odds of being prescribed OAT, while if the injury was work-related, it reduced the odds. Another way of interpreting this is, as mentioned before, we believe that OAT is an indicator of opioid use disorder. So another way of looking at this is that being younger, being male, and living in the lowest income quintile are risk factors for developing opioid use disorder. So taken all together, what we found in the study was that opioid use disorder after an injury was predominantly influenced by prescription before their injury. This was unsurprising because both clinicians and patients will likely follow the same regimens for pain management if they've been found effective beforehand. What we also found was that overdose risk was highest among those opioid use disorder, which was also unsurprising, as we know that is a risk factor. However, the magnitude was very interesting to us because it was over 28 times the risk, and it was higher than all the other risk factors we identified combined. We also found that opioid prescription increased the risk of overdose by 33%, but that effect size was not as high as other risk factors, such as being male, which had 83 times higher risk, being younger, which had 21 higher risk for every 10 years in age, and those living in the lowest income quintile, which has 39% higher risk compared to the middle quintile. We also found that the risk factors for developing opioid use disorder were the same as those who risk factors for overdose, which were being male, being younger, and living in the lowest income quintile. So what this means is we believe that intervention in this opioid use disorder cohort is absolutely necessary in order to reduce our overdose cases. And because most of these overdoses occur in private residences, we think that active monitoring of these individuals would be absolutely necessary. And also because many of these individuals also have comorbidity of mental health issues, we think increased access to counseling or therapy services will be very beneficial for these individuals as well, so they don't need to resort to illegal drugs in order to manage their pain. Sorry. We also believe this supports the a more nuanced approach to opioid prescription for pain management purposes, as we know that opioids can be very effective in managing pain, and we show that the increase in risk is not that high compared to other risk factors, so they can also be relatively safe. But if the patient falls within the higher risk profiles of those that are likely to develop an opioid use disorder or overdose, mainly being male, being younger, and living in less affluent neighborhoods, additional care is needed before prescribing opioids to these patients. And finally, I would like to disclose some limitations we had with our study. First is that we used first injury cases events as our indexed events, and we used first overdose events as our overdose event. But these may not be true first events, as we cannot capture events that occur before the start of a study period. Similarly, overdose events are likely estimated and underestimated in our study, as we cannot capture any events that occur after the follow-up time, after the end of our study. And also, we were not able to tease apart whether the protective effects of a work-related injury was due to return to work protocols or merely with employment status, again, to the limitations of the administrative data set. And lastly, income quintiles were calculated at dissemination area level and not at the individual level, which may contribute to ecological fallacy. So thank you all for listening, and I'd like to give a special thanks to my colleagues and team at BCIRPU, at Fraser Health Authority, Surrey Fire Services, UBC, and the University of Fraser Valley. I'm happy to take any questions that you may have.
Great, thanks, Alex. So if you have any questions, feel free to use the chat feature at the bottom of your screen, or you can unmute yourself to ask a question. Alex, maybe if you wouldn't mind, I'll start off. Do you have any future plans, or does the injury unit have any future plans to perhaps take this work forward, or anything that is planned in the near future for this work?
Yes. So one thing we would like to investigate more is on the protective effect of the work-related injuries, because I think since it did have, we found that it has a fairly strong protective effect. We would really like to tease out what contributed to that protective effect. And also, this study was focused on just Fraser Health, and we think that if we're able to get the funds, that we can expand this to the whole of BC or even to other provinces as well.
Great, thank you. So we have a few questions in the chat box, so I'll just go through them one by one. The first one is, can you elaborate on the nature of injuries in your data set? And were you able to tease apart instances where people used minor injuries for drug seeking versus serious injuries?
Very good question. We included all injuries that required at least a emergency department visit. So any minor injuries that only required a clinic visit were not included. So we believe that should eliminate most of minor injuries for drug seeking purposes. Yeah, I hope that answers that question.
Okay. Our next question is, curious to know if the researchers looked into the sectors of which the participants were working in.
That's a very good question. That was definitely one of the original aims of this study. However, due to limitations in the WorkSafe data set, pretty much over 50% of the WorkSafe claims did not have had either unknown or missing for the type of sector that they worked in. So we weren't really able to interpret those results. But we did find that those participating in the constructions or the textile trades have a increased risk or rate of overdose. But it's because of the number of missing values that we had, we are not really able to interpret and conclude from that analysis.
Okay. The next question we have is, has injury prevention for young males in high risk injury been considered for budget requests to the Ministry of Mental Health and Addictions for Pathway to Hope strategy? Perhaps this is a question as well for our general audience here. If anyone has an idea, feel free to pitch in.
Yes, I am not as familiar with the Pathway to Hope strategy.
So we have another question back to the study. What do you mean by younger as a risk factor? Would it be specific age range?
So in this study, we kind of group our ages by 10 years, so 15 to 25, 25 to 35. So what we find that the younger the age group that they are, they had increased risk of either developing OUD or overdose, opioid use disorder or overdose risk. And to get back to the previous question, we do acknowledge that this being male, being younger, and living in low-income neighborhoods are risk factors for many many things at a sort of systematic level, such as for injuries, for opioid use disorder, for overdose. So it's definitely more of a system-wide risk profile than just for overdose.
Okay. The next question, I am wondering, for patients admitted to a trauma service where there is a team of multidisciplinary team involved in the care of the patient, like a pharmacist and the chronic pain service, was there a change in what the patient was prescribed on discharge?
Unfortunately, our data doesn't allow us to answer this type of question. So I can't, so I can't really answer this question.
We have a comment, just thank you for the wonderful presentation, as well as a question. Do you think the injury severity score could also be an important predictor if that's available?
Unfortunately, we didn't have that available. However, we were able to separate those who had just emergency department visit and those who were hospitalized as well. So that could be used as sort of a average injury versus a more severe injury indicator. What we found with that analysis was that if you were hospitalized, if you had more serious injury, you were more likely to be prescribed opioids, but it didn't really affect the overall risk or the basically overall effect sizes of the analysis that I presented here. So that's why we didn't separate it.
Okay. The next one, so Emily, this webinar will be recorded and it will be uploaded to our website, so keep an eye out for that. But there's also a question to describe the time frame from injury to overdose death used in your study.
So our study period was between the fiscal years of 2012 and 2017. We chose 2012 because that was the start of NACRS, and we needed NACRS in order to get our emergency department information for both injuries and overdoses. And 2017 because that was the most recent data we had that was shared among most of the data sets.
And then our next question is, are there any plans to delve deeper into the PharmaNet data to see if these individuals are prescribed other medication to suggest mental health issues or previous injuries, including antidepressants, neuroleptics, or antiepileptics?
This is a very interesting question, and I think there's definitely interest. However, I am not sure how familiar you are with POP data and how they work. Basically, every data request, and for them to link it, we had to submit everything ahead of time. So unfortunately, this was not something that we particularly thought of or to submit. So in our data, we don't have any other medications other than opioids and OAT. But this is an excellent idea for a future study.
If there's any further questions, feel free to use the chat box. Again, or you can unmute your audio lines. So we do have another question. Was traumatic injury a better predictor of opioid use?
I'm not sure how to answer that question exactly, because we're only able to separate out serious injuries. E.g. previous car crash, bodily harm, require hospitalization. So we won't have information on a previous car crash, and we didn't really separate the different types of injuries. We just took injuries as a whole, and we were only able to separate a serious injury from a not so serious injury by the hospitalization. So we don't have information whether they were admitted to a trauma center or not. So I'm not sure how to answer that question. And what we found was that if you were hospitalized, you were more likely to be prescribed an opioid, but you were not more likely to have an increased risk of overdose or leading to an overuse disorder.
Did you look at the length of opioid prescription post-injury, plus the number of prescriptions filled?
Yes, we attempted to look at this. And again, due to the limitation of the data, what we had was the number of days filled and number of days prescribed and the number of opioid prescriptions. But we didn't find any clear patterns between the number of days that they were prescribed opioids and overall overdose risk or increased risk in developing opioid use disorder.
And Emily has a question about also morphine equivalence. I'm assuming you mean if we looked at morphine equivalence?
That is not something we looked at. We did not have. I think what you mean here is, do we have the strength of the opioids in terms of morphine equivalence? If so, that is not data that we have.
And our next question is, I'm also wondering if self-harm injury was associated with opioid risk or if that was related to the disorder likelihood.
That's a very interesting question. Very good question. And unfortunately, we really didn't have an indicator to show us which injuries were self-harm and which injuries were not. So we were not able to look at that relationship. These are very good questions for our future studies.
Okay, if we don't have any further questions for Alex, I want to thank Alex for your time today and for presenting for us. Again, if some of you may have joined later on, the recording will be available on our website, and I will get our communications team to send that out. And we look forward to seeing you next time. And the next webinar details will be up on our website as well on our mail outs. And thank you for joining us.
Thank you, Anita. Thank you, everybody.
Thank you, Alex.